Okay, so today, thanks again for having me here. I'm going to talk about addressing the sexual changes that happen with breast cancer treatment. And interestingly enough, this isn't an issue unique to breast cancer patients. It's a problem faced by women who receive any type of cancer treatment, or even women who are at really high risk of developing cancer, who are put on certain medications to prevent breast cancer. So hopefully, I'm going to run through kind of my step-by-step process for addressing these issues. But first, let me just tell you who I am. So obviously, my name's Dr. Kristin Rojas. I'm actually a breast cancer surgeon, but I come from a unique path in that I originally started as a gynecologist. So although the majority of my patients have a history of breast cancer, I do kind of put my GYN spin on everything. And that's originally how I became really passionate about addressing these issues. When I started my training and went into practice, I was surprised at how many women experience these side effects, and looking more into it, realize that it's almost a universal problem. And as a society, as healthcare providers, we don't do a great job addressing it. And so I started a program called the Music Program. It stands for Menopause, Urogenital, Sexual Health, and Intimacy. And so it's geared towards women with a history of any type of cancer. And right now, it's actually in flux. I'm moving from New York to Miami, so this program will be available in Miami, but I do have some online tools as well, and we can talk more about those at the end. But first and foremost, I have no financial disclosures. My program isn't a nonprofit. I don't, although I'm asked to sponsor a lot of products frequently, I actually don't have any financial relationships with any products. So I will call things by their brand names, but these are just personal endorsements from my patients, from running this program, or things that I've looked into that I think are good ideas. Lastly, I'm a doctor and I went to medical school, and I've gone through what feels like a million years of training, but this is just my expertise and not formal medical advice. So anything I talk about, if you have a question, always talk to your oncologist that knows you best.
Yeah, and just really quickly, I was going to mention, letting our audience know, if questions do come up while Dr. Rojas is speaking, please just pop those into the chat box and we'll be able to address those at the end.
All right, so when you started treatment, or when any of the members of your organization started treatment, they may or may not have received information about the sexual side effects. There's a million things to talk about when a woman is diagnosed with breast cancer, and a million questions in her mind. Are you going to survive? Like, what's the treatment? Am I going to need chemo? That's like the first question that women always ask. But interestingly, and so when you start to feel these side effects, you may go to Google and kind of see, what are these side effects, and do other women with cancer experience them? And it turns out when you Google sexual dysfunction, it's all about erectile dysfunction.
Yeah, and that's something that I've noticed. It's really, sexual dysfunction is about Viagra. It is about the males. Yeah. It's always about male frustration. So it's interesting that when you do Google it, it's the only thing that comes up.
Yeah, and the other thing is, somehow in society, it's okay to talk about erectile dysfunction. It's okay to talk about men with sexual issues. But all of a sudden, if you start talking about it from a woman's perspective, it's like taboo, and, we shouldn't talk about it. But it's actually a really important part of everyone's lives. And my goal is just to make this normal conversation, and for everyone else to think it's normal too, so that once, we talk about it, then we can start addressing these issues. And actually, when men present to a urologist for prostate cancer treatment, there's been studies showing that 80% of them are warned about sexual side effects from their first visit. So men have the choice to decide what treatment they choose, whether it's surgery or non-surgical options, depending on their side effects. And I think that we do a pretty good job warning men about that. Yeah.
Interesting.
But maybe not so much for women. So that's kind of the background here. But, anytime I talk about treatments that are going to be addressing hormonal side effects, I like to just do like a really quick primer. I'm sure all of your members are very well educated in the type of breast cancer they have. I'm always so impressed with how self-sufficient and how knowledgeable everyone is. But
it's all about the note taking. Yeah. Bringing in the notes to you, sitting in your office with a bunch of notes.
Yeah. And everyone asks such good questions, but just a brief primer, just to generalize different types of breast cancer. First and foremost, everyone's breast cancer is unique, and women who have estrogen sensitive breast cancer, one woman, her treatment may be completely different from another woman who has a similar type of cancer. Everyone is different. So women who have hormone receptor positive breast cancer, their tumor cells have something called the estrogen receptor. Now, this actually doesn't mean that there's too much estrogen in your body or that something's wrong with the estrogen floating around your body. All it says is that those cancer cells actually just respond to that type of signal. And so we use that as a way to kind of address preventing recurrence, and with different medications like tamoxifen and aromatase inhibitors. And they usually get estrogen blocking medication. But women who have triple negative breast cancer, although they don't have cancer, one doesn't get tamoxifen or aromatase inhibitor, she may be feeling the same symptoms as a woman who does, because chemotherapy can make you feel the same. Lastly, there's HER2 positive cancer, and usually those women get a type of chemotherapy, plus or minus the estrogen blocking medicine. So, and this is all in effect to, in addition to the effects of surgery and radiation on a woman being, with the loss of one or both breasts, or even just a big scar. And so this is all in addition to that. It's really a multifaceted problem that it really attacks you in different ways. And so some of the things I'm going to talk about address the medications that you receive. So these are some artistic interpretations of the uterus and the ovaries. You have two ovaries. They make estrogen. Menopause, chemotherapy, radiation, ovarian suppression blunt the effects of the ovaries. When I say radiation, I mean women with a history of pelvic radiation, so not necessarily breast cancer patients. But women who are on AIs, although they experience some of the same symptoms, but in a different way, that actually prevents the fat cells in your body, and everybody has them, from making extra estrogen. So they produce similar symptoms. The other thing is tamoxifen and raloxifene can actually work specifically on the vulva and the vagina and block the effects of estrogen there. So the vulva, I tell patients, is like the outside of the vagina, and the vagina is the internal part. And so it's important to kind of understand the difference between those two terms, because I use them a lot. So what are the effects of having this really low estrogen? So normally, normal menopause, estrogen slowly decreases with time. It's a very slow process. But when we give a woman chemotherapy, we jumpstart menopause, immediately drop her estrogen, and your body actually goes through what's called, it's basically like a drug withdrawal. You feel hot flashes, you're sweaty, mood changes, you feel terrible. And so normal menopause is 51 to 52, but we artificially make women in their 30s in menopause, and it's a very abrupt menopause. So your body's like, what is happening?
And that
and
is it's a direct effect of chemo, but that's the goal, right? Is to put a young woman into menopause so you can stop her period and get those cancer cells in control.
Well, the way it works with breast cancer is that chemo targets rapidly dividing cells. And so cancer cells are growing out of control. But the ovary, every month when you ovulate, those cells are dividing and growing. So it actually, think of it as like collateral damage, actually. So chemo inadvertently affects the ovaries. We give you Lupron to kind of protect them, to kind of hide them from the effects of the chemotherapy in young women who are trying to do fertility preservation. But then these other medications specifically do block estrogen, like the ones we give by mouth.
Okay.
Yeah, so, we have these hot flashes, which everyone knows are menopausal symptoms, but what a lot of women don't realize is that they can have profound effects on the vulva and the vagina. So that means less lubrication or dryness, but this also translates to less stretchiness of the vagina. So normally during sex, the vagina is stretchy, and it is able to accommodate the physical act of penetration. And when the vagina loses that stretchiness, sometimes you can have pain, spotting after sex, which can be really scary. And then the other effect is that the normal vaginal pH is actually low. It's a little bit on the acidic side. And there's a very careful balance between good and bad bacteria. It's like a natural ecosystem that, we try not to disrupt. But when we drop the estrogen, all of a sudden, the pH actually goes up. And this fosters the growth of some common infections like BV, Candida, or yeast infections, and even bladder infections. So additionally, with low estrogen, you get mood changes, which everyone knows what I'm talking about there, I'm sure. And then long-term, can affect your bones and your heart. So it's important to stay active, and that your oncologist will be keeping tabs on your bone health.
So you're suppressing, right? We've got to suppress basically our periods. And I know that one feeling, along with having my breast removed is the menopausal symptoms and the tamoxifen and everything combined. It kind of, you wonder if you're even a woman anymore, right? Like you just go from having a regular period all your life, and that's your identification. It's your grounding as a woman. And then all of a sudden you don't have any of that. So coupled with all of these physical changes are the immense amount of emotional trauma that it causes. And I know that at some point you're just kind of wondering, am I even a woman anymore? And so, those are a lot of, I feel like a lot of conversations that we do have within our survivorship community. How do we define ourselves as women, even physically, if we're just suppressing?
Yeah. And you're not alone in the way you feel. A lot of, I have heard other women say that, and it's interesting because that would have never been something that I would have thought of. So that's why the patient perspective is so important. But, while a lot of women do share that feeling, for some, periods can be really, they kind of associated with the negative aspect in some women.
Yeah, of course. They're not
and
easy.
So
it's
but that's why your unique perspective is so interesting. And that's also why there's not really a one size fits all approach to addressing these symptoms, because everyone brings to the table different, cultural ideas and personal feelings and their own experience. But just because your period has disappeared, the functional reason for a period is for, your estrogen is signaling to your uterus to grow the lining of the uterus, which is the endometrium. And then when you don't get pregnant every month, that endometrium is shed, and that's your period.
So it's like a cleansing almost, right?
Well, yes, it is. But, there's also, if you don't have a thick endometrium, meaning like if you don't have the signal for estrogen, a lot of women ask me if I'm not having a period, it's like, is the blood building up somewhere, or am I not healthy? But sometimes, it's not medically necessary to have a period. And even when you look at, even when you look at like the historical, issues with the birth control pill, like even the period you have like on a birth control pill, that's actually something that the Catholic Church wanted in the pill design, to give you this like fake period every month so that it seemed like more like a natural cycle. And then they ended up not liking the pill anyway, so it didn't even matter. But it kind of just stuck around. It's not even a real period. It's just a quick little 4-day drug withdrawal that causes spotting. And so, the physiologic changes that happen with a period, without having that estrogen signal, you don't actually need one, but it does also seem to compound to other losses that you've experienced.
Yeah, that's what it is. It's the mix of that perfect storm where you're like questioning, I don't have breasts, I have no idea what's going on with my body, and I'm a raging bitch in my household. And like all of this combined is the really challenging part, right? But but I understand what you're saying, and those are good, hopeful words to just keep reminding ourselves. Don't need a period. Don't need a period.
Yeah. And even though, we're blocking hormones and making them really low, you still have some hormones. And there's just ways that we can kind of harness the natural hormones that are still happening to make you still have different instincts and urges. And you can still maintain all of the aspects of yourself that are feminine and that you value. And that's kind of I try to give patients more tools to do that. But for some, losing their period it's like just adding to another loss. And so I try to frame it differently, but
That's good.
That's hard.
That's a good frame. So let's keep talking about sex.
Sure. So the first thing is I want everyone who watches this to start talking to their oncologist about these symptoms. The first thing is bring it up. You have nothing to lose. You've already been through a diagnosis, part of a complete treatment. Like, you have nothing to lose. Once you bring it up, because, oncologists as doctors, we aren't really taught how to address sexual side effects in medical school or training. The more you bring it up, your oncologist may not have an answer for you right then, but I can bet you if they're a good oncologist, they'll go home, they'll look it up. If multiple patients ask them the same question, next time they may not have an answer for you then, but next time you see them, they may have a solution for you and be more equipped to talk to you about your symptoms. So it's important to start the dialogue, know what to expect, and they can really help, once you have that dialogue, prepare you for different aspects of your treatment. I'm going to talk about daily moisturization, which I want everyone to start now because it can actually affect a lot of different aspects of sexual health. And then they can help you with managing pain, and then even considering dilators through treatment. And although dilators are pretty scary, I do recommend them a lot, and I try to kind of frame it in a non-scary way. So those are some of the things that you can start now. So the first aspect I address is dryness and painful sex, because they really are connected. And I like to address them before I go to libido, because sometimes by fixing the pain with sex and stopping that negative feedback loop, you can sometimes kind of change the way your body thinks about sex. And so I kind of start here and go step by step. So the first thing is to avoid irritants. So like I said before, the vagina is this like beautiful, miraculous ecosystem of good and bad bacteria. So I tell patients, just avoid products, soaps, anything that has extra chemicals in them, because a lot of the vulvar irritation that women experience is actually a contact dermatitis or allergic reaction. So, when you start to feel these symptoms, a lot of women like rush out to get like Vagisil, Summer's Eve, Vaseline, or even like vinegar. I've heard it all. And so I try to just frame the conversation, try to limit what you put on that delicate skin, because it is so delicate. And there's a lot of hidden chemicals and things that we don't even realize. And you definitely don't want those in your vagina. So first is, first is to limit like crazy chemicals that come near your vagina. And so that means no douching. And it's cleverly called feminine wash now, I've noticed in the grocery store. So just like stay away from feminine wash. You don't need it. You don't need those perfumes. Those fragrances are also found to be endocrine disrupting compounds, which can affect how your cancer is treated. So just stay away from them. This unfortunately even means kind of avoiding like soapy bubble baths. So if you're a bath taker, I tell patients just like use a natural oil, but avoid like really bubbly baths, because sitting in that for a long time can kind of wreak havoc on that ecosystem. Staying out of hot tubs for a long time, and then just rinsing off when you get out of a hot tub or a pool, because that chlorine can kind of be the same thing. Not staying in your wet swimsuit, basic stuff, but things I just like to review. Tight pants or leggings can cause irritation that ends up manifesting as pain. Avoiding fragrances, additives, and that's anything that touches the vulva of the vagina. So detergents you use to wash your laundry, panty liners, tampons, even toilet paper, and consider at least temporarily until your symptoms are under control, no waxing and trying not to shave. And that's like really hard, because everyone's always asking me, Megan, like, well, what am I going to do? Like,
it's bikini season.
But I tell them like, actually the trend is kind of going in the other direction now. So just like, that used to be like totally bare, but now like, just give yourself a break. I feel like give yourself, and just try to avoid anything that like hot wax is going to irritate that skin. So just take a break, try to address these symptoms. And then I'll tell patients like, try just to trim and see how it goes. But, anytime you're doing waxing, and these are hard symptoms to address because it's part of our culture. So I kind of just always go with that. But the last thing is sleep with no underwear on. So one of the bad actors of the bacteria in the vagina is called Gardnerella. Overgrowth of Gardnerella causes BV. So the thing about Gardnerella is it hates air. And so if you sleep with no underwear, and then just make sure that area stays nice and dry, it can really help keep BV at bay once the pH gets disrupted from these medications.
Gotcha.
So the first thing is daily moisturization. So this is different from lubricants, because lubricants are before sex. So I want women or sexual activity to kind of just make those distinctions in their mind.
Separate.
Because just like you moisturize your face every day, you're going to think about the same for your vulva and your vagina. And usually after a shower is the best time, because your skin can absorb the moisture the best. You can apply moisturizers to the external vulva, which I've highlighted with the blue circle. And then you try to find products without additives. But moisturizers with hyaluronic acid or lactic acid are actually great products because they help restore that vaginal pH, lower it a little bit like I talked about before. And moisturizers can be hormonal or non-hormonal, and I'll kind of talk a little bit about that.
Yeah, that'll be an interesting conversation just because, you know, it's at some point you'll have a doctor say, if you have a hormonal cancer, stay away from all hormones in products and foods.
Yeah.
So.
Yeah, and it's controversial. So, you know, vaginal estrogen is different from estrogen that you take as a pill. And there were some big studies in the early 2000s that came out about estrogen as a pill that really scared everyone about the breast cancer risk. And I actually talk a lot about this on my podcast because I think a little bit was misinterpreted and it kind of carries over into the vaginal estrogen world. But there's no evidence to show that vaginal estrogen increases the risk of recurrence. But it's all observational data. So a lot of times the way I approach it, because it also is associated with a lot of anxiety, I start with non-hormonal products because a lot of times I can get the symptoms under control without hormones. And then we don't even really have to go there. But if women have really severe symptoms and it's not helping, I do sometimes use vaginal estrogen.
Gotcha.
So my first go-to is a moisturizer like organic single ingredient coconut oil. You know, I was practicing in Brooklyn and my Brooklyn patients really liked the idea. Like, I didn't want patients to have to go out and buy something, and everyone has coconut oil and is super into like natural everything. Yeah, it's good for everything, your hair, your dry skin, everything. So as long as it's single ingredient or organic, I say go for it. Place it to the external vulva after a shower and see how it goes. Try every day, but if you have like too much product buildup, you can space it out. If that's not really cutting it, I bump patients up to something with a hyaluronic acid. And that's actually, it sounds like an acid, like scary, burny, but it's actually a molecule that pulls moisture from the environment and holds it onto the skin. So, and it's used in like a lot of face creams and eye creams. And so these are some good brands that I like. Hyalogine, those are all online, Reverie. I don't love a lot of Vagisil products, but the Pro Hydrate product does have hyaluronic acid, and then Membracin is another one that you can find online. Good Clean Love is a great company, uses a lot of natural products without extra chemicals, and they have a moisturizer called Biomatch that has lactic acid. And then things like Replens are okay. They're safe with condoms, but sometimes they can leave a film. And so, you know, if you're someone who is relying on condoms for STD protection or contraception, you know, make sure you check labels, and you don't want to use an oil because that can degrade
with a condom. Okay.
Yeah. And so that's externally, but you can also use suppositories, which are like little pellets, and you can place those in the vagina, like vitamin E suppositories or these hyaluronic acid suppositories by Bonafide. And then, you know, so I start with those, and then the next is vaginal estrogen. And like I said, this is very complicated. I separate it with my patients from oral estrogen. It's actually the most effective treatment. And if you're someone who has recurrent bladder infections, which can totally ruin someone's life outside of all these other things they're experiencing from treatment, then it can be really helpful. So you know, and they make products that are really low dose too. Yeah.
And this is like a really good topic because I know when it was suggested to me, I was like, this is crazy. You know, like it's just, you know, you're told to stay away from hormones. So why is it okay to put it down there? Your body is still absorbing it.
Yeah, and it's kind of mixed messaging. It can totally be confusing, but so the vaginal estrogens are lower dose, and so there is absorption in the beginning when the vaginal mucosa, which is the lining of the vagina, is very thin and not very stretchy and like prone to having those little spotting episodes. But actually after the beginning, they've shown that absorption decreases with time, and you don't use it every day. You can use it 2 or 3 times a week, and the dose is so low. We start with like 4 micrograms twice a week, which is a tiny dose. And, you know, sometimes it's, and I do have patients who nothing else works, and I talk to their oncologist, and then their symptoms resolve with very low dose vaginal estrogen, either once or twice a week. And so it can be an option for women that are really suffering. I just preface it with this conversation.
Okay, great.
Yeah. So it's also helpful when we're doing vaginal remodeling. So the vagina can actually shorten if your estrogen is really low for a long time. So sometimes I just use it for a little while we incorporate a dilator regimen and vaginal estrogen.
Can you like describe what vaginal remodeling is? I'm just curious.
Yeah.
I've never seen that term.
Yeah, I made it up. That's probably why. Yeah.
Okay, please explain.
Definitely. So the vagina, like I said, is supposed to be stretchy, and it's supposed to stretch long ways and width-wise when you have penetrative intercourse. It loses the stretchiness, so it stays short and it stays narrow, and that is what can make sex very, very painful. So the only way, like moisturizers help with improving the pH, improving the moisture, but they may not give that stretchiness back like vaginal estrogen might. So after I examine a patient and I see that they have really serious vaginal stenosis, meaning narrowing and shortening, sometimes I'll recommend a dilator regimen, which basically helps to gradually stretch the vagina back out. Using vaginal estrogen at the same time basically helps kind of reverse the clock per se, and kind of go back to when the vagina was a little more stretchy, and you can kind of get that link or the ability for the vagina to stretch during sex, and that can really help with pain and also decrease spotting with sex.
Okay, that's a really great term, but even better of a treatment. That's awesome that you offer that. That's great. Yeah,
it's kind of, it requires a lot of patient dedication, and I have to explain everything, obviously, but you know, everyone says, oh, treat dryness, treat dryness. People don't realize that when you're on these medications for 5 or 10 years, the vagina completely changes shape. It's not just, oh, treating dryness is supposed to fix everything. And I think that's how a lot of women get frustrated. Like, nothing's working, you know? I'm using these products and I'm still having so much pain. And sometimes it's that we need to just really think about changing the art of the vagina a little bit. Yeah, so estrogen is not for women with a history of uterine cancer, because those directly respond to estrogen, and it's right there sitting next to where you're putting it in. So I do sometimes use for breast cancer with estrogen receptor, but not for those women. And so vaginal testosterone is a newer product on the market. Androgens like testosterone, DHEA. These are a commercially available product called progesterone or Intrarosa, and ASCO has actually officially endorsed vaginal DHEA. So if a patient has commercial insurance and they can get this coupon program with Intrarosa, sometimes I'll just get vaginal estrogen and go straight to these progesterone suppositories because they can really help with painful sex. They work in a similar way, and it's not estrogen.
The testosterone does the same thing as the estrogen.
Yeah. Testosterone and DHEA are similar. They're like similar chemicals in the biochemical pathway. But the way testosterone works is the fat cells in the vulva and kind of like locally, it may convert it to estrogen just right there. And that can,
interesting.
And so you have like a little bit of a local effect that may be more subtle than using vaginal estrogen. And so there's some studies that have come out showing that women who use vaginal DHEA, they measured their estrogen levels, women on aromatase inhibitors, which is a lot of women, and the estrogen levels didn't change. So it kind of
interesting.
So your body doesn't see extra estrogen, and I think a lot more people are comfortable with that.
Okay.
The only thing about vaginal DHEA is it is kind of in the testosterone family, and some newer triple negative medications work by blocking testosterone. So before taking any hormonal treatment, just talk to your oncologist and make sure that they're on board.
Yeah, definitely.
But this is a world that's changing. More people are starting to recommend vaginal hormones, even women with a history of ER-positive cancer. So next is my favorite topic. It's lubricants. You know, when we go to our OBGYN, like national conferences, there's like, you know, the products that they're showing, like vendors, and there's actually something called a lube bar. And it's literally like, you can go and play and try all these different types of lubes. And it's like my favorite thing about going to our medical conference is seeing like all these cool products that people come out with. So it's for everyone, every single time, anytime, even if you don't think dryness is really a problem, lubricants, I just say every time, because it can help with symptoms that you don't even know that you're having that may be causing the pain. So there's different kinds. Yeah, there's water-based, which is less irritating, doesn't stay in the sheets. You know, with these lubricants, you also want to keep the same principles, so no extra chemicals, fragrances, dyes, anything that's warming you want to stay away from or that has a taste. Yeah, just like stay away from it. No extra stuff. And so a lot of products are made to not have these extra parabens, etc. Water-based is good for silicone toys, which I'll talk more about. Sometimes a little bit stickier. It doesn't last quite as long. Personally, I think silicone-based lubricants are the best. My go-to brand that I recommend to everyone is Uberlube because it has like no extra stuff. You can order it online, and it even comes with these like cute little travel packs you can just like throw in your vacation bag or whatever, and like no drama. And it actually was, I actually had a bunch of samples, and I got like stopped in the airport once, and that was kind of like hard to explain, but I was bringing all these samples back to the music program, but it was,
Gotcha.
But anyways, travel packs are available, but it's long lasting, hypoallergenic. It's just really, really slippery. So if you get it on the floor, clean it up because you don't want to fall. And then there's hybrid lubricants as well. Oils like coconut oil or olive oil, just remember no condoms if you're going to use them. And then there's newer products now that actually have CBD in them. And Good Clean Love, which is a brand that I like, has a new product with CBD lube. Foria has one as well. And then another one from Quim. The deal with CBD is it's gaining popularity. We don't have a lot of data on, it's not a regulated industry. So number one, any CBD product you use, whether it's by mouth or topical, like a cream or a lubricant, you have to make sure it's a reputable buyer. They can use pesticides that aren't regulated, and the quantity of the CBD can be different, and they can actually have THC in it, which can actually produce some of those psychoactive effects like confusion. So you want to make sure it's a straight CBD product, but because it's not regulated, there can be THC, which can be absorbed and may affect a drug test. So if you're someone who needs to take a urine drug test for work, just stay away from CBD products for now. They probably help with inflammation and pain. There's just not a lot of data. So some people are like really into CBD, and I don't try to stay away from the comments on like taking it orally, etc. But I think, these brands that I like are coming out with these products. So I'm open, and some patients swear by them. So the important thing is just to avoid glycerin and petroleum and these other chemicals.
Can you really quick, just on silicone, it just sounds like a scary term to be putting on your vagina. I know a lot of vibrators are made of silicone or whatever, but it's safe, I'm assuming.
Yes, so silicone isn't absorbed. It's different from the drama, like when you have silicone implants where, a lot of people are talking now about implant-related illness. And actually silicone toys are preferred because it's a non-porous material. So like bacteria can't hide in those little, in the porous materials you might get with other plastics. And silicone is safe and better than other plastics. Like I do talk a little bit about endocrine disrupting compounds that are in other plastics. Silicone doesn't have that. So I encourage patients to use it for a lube, but the bigger thing I think is avoiding all the other chemicals.
Gotcha. Okay. Interesting.
Yeah, good question. So pain is really, really common, and everyone, we don't prepare women and then they have sex and then it's painful and then they're like, something's wrong with me. This isn't right, but it's actually very, very common. A lot of things I talk about are related to pain. So I incorporate dilated regimens to patients. I show them how to place them sometimes in the office, but the way I explain it is, find some time 2 or 3 times a week, 15 minutes, uninterrupted. Listen to a podcast, take a bath, do whatever to relax a little bit. And then you start with the smallest size and you put a lot of silicone-based lubricant on it. And you're just gonna, like, if this is the outside of the vagina, you don't need to put it inside. Sometimes just setting it on the outside and letting your body kind of relax a little bit, because by the time a lot of women get to me, they may have already have a lot of anxiety associated with anything going in the vagina because they keep having these painful experiences over and over again.
Yeah.
So sometimes starting with really baby steps, like just setting something right there and kind of relaxing for a little while, can help retrain the brain so that you don't have that. And then you just go little by little, and you can just place the dilator, like centimeter by centimeter, a little bit more, and use a lot of lube. Sometimes I have patients listen to a podcast. I tell them to try it 3 times a week, and this can help gradually increase the length of the vagina. And then pelvic floor physical therapy can also be really helpful. So I'll try to find a good one wherever I am and recommend them to patients. So pelvic floor physical therapist, though, not just a regular physical therapist.
Yeah, I actually found a lot of help from somebody in that area.
Yeah.
And when you can find someone really good who's connected in with all those muscles, it actually makes a really big difference.
It
and
does.
back problems, everything. So stomach strength. So
yeah, the pelvis is like a bowl like this. It holds all your organs in, but there's all these muscles that are interwoven. So if one is spasming and you don't even realize it, because you don't even realize it can cause all this pelvic pain. And people that are trained with pelvic floor PT, it's hard for me to get patients there, but once they're there, they do a lot better.
Okay.
So lastly, and the most complicated topic is libido. And, you know, I have patients talk to me all the time. Like, I feel dead inside. I used to want sex all the time and now I don't. Like, what's up with that? And first thing to know is this is not a problem unique to women with cancer. This is a very, very, very common problem. And as a society, we're not doing a very good job addressing it. There's 5 types of Viagra. Yeah. But
I feel like there's nothing for women. And I feel like in that, and just talking to one of my sisters recently too, it's like you talk about sexual dysfunction or interest, right? You have a different schedule. Maybe you're working more, and then you've had a child, which adds other layers. And then in another group, then you've had cancer. And then there's all this, you know, discomfort emotionally in your world, and you go to seek assistance, and it's all about, you know, men's Viagra, or that, you know, there's lots of, you know, masturbation talk for men. And like there's all kinds of stuff that seemingly supports men. So I'm just glad this conversation is here, because even prior to cancer, it's complicated. We are, you know, women are emotional beings too. So there's a lot of different layers there that comes with sex or making love or finding the right partner. I mean, there's so many.
It's multifactorial, and there's like a lot of different aspects that contribute to it. Not everyone's low libido or low desire is the same. And so I start with a couple like non-pharmacologic interventions, like lifestyle modifications, to see if we can help. But then there's some things that, you know, are outside of my realm of expertise. Like, for instance, couples counseling or communication issues. Like those, if patients are having those, which it always comes up, you know, go talk to someone. There's like no shame in that at all. And it can be really helpful and give you the tools you need to communicate with your partner, which is huge.
And I think a lot of this too, like you're saying, there's so many different things that happen during cancer. So there's a lot of different levels of, you know, I don't have my breast anymore. I'm taking hormone suppressants. I don't feel like a woman. My vagina feels numb. I mean, there's so many different things that come up. So, and it sounds like you're able to well direct people to get all the different layers taken care of. So libido is a sensitive topic.
Definitely. And even as a provider, it took me having this program a long time to feel comfortable even talking about it. And that's me. And I'm like going around trying to make it normal conversation, but it's hard because society like dictates that we should act in a certain way and say certain things. But the first thing is to address like pain, moisturization, all those issues first, because that can help. If you're decreasing pain, then it's because you're not going to fix your libido. Every time you have sex, it's super painful. So medications are obviously usually the culprit for women with a history of cancer, but tamoxifen actually may have less effect in zapping the libido than an aromatase inhibitor. So tamoxifen gets a bad rap, but sometimes trying to change between the two can help the symptoms a little bit. And so that's something that you can talk to your oncologist about. The other thing is some antidepressants can cause low libido, like Zoloft, Celexa, etc. So in patients who are on one of those, and I do think sometimes patients should be taking medication. You know, cancer can cause huge mood disruptions. And I'm not saying don't take medication and don't stop taking your medication if you're on one, but talk to your psychiatrist about taking bupropion instead, maybe considering it. And it's not for everyone, but it doesn't have those sexual side effects that the other SSRIs do. You want to address communication, relationship issues. I tell patients, start exercising today, because exercise increases your natural testosterone, and testosterone is what makes women's libido go. And so and then you're also feeling a little bit better about your body. Your brain chemistry changes, you know. And so that's the first helpful intervention that also helps decrease your risk of recurrence. The next is go ahead. Sorry.
No, I was just on the exercise part. Like, does that include masturbation? Like, you know, that's like the topic, right? Because I mean, not everyone has a partner. And again, you seek for information out there, and it's an awkward subject. but like, yeah, practicing, is that exercise? I mean,
yeah, definitely. Like, so if you haven't thought about sex, or you're someone who had an orgasm all the time, but you haven't had one in a really long time, like that information highway in your brain, like think of it as like the road lights are off. And so like your brain's less likely to go there if you do that less frequently. If you try to start thinking, like rev up the way you think about things, and women are different than men, like it's not an automatic thing. And so think about like, things that make you feel sexy, whether it's watching something or listening to something or imagining something, and kind of going into that mindset. And then masturbation, like it's normal, and it can really also be an amazing tool to help you rediscover your body, because after treatment, your body is completely different. In your anatomy is different. Your vagina is different. Your vulva is different. What may have felt good before doesn't feel good anymore, but there may be something else that feels good, or maybe other parts of your body that can turn you on. You don't even realize, and you probably won't figure it out right there in the moment with someone else when it's kind of like game time, but you need to like kind of think about it, allow yourself that self-care and that time to kind of get to know your own body. And so I always encourage patients to do that. And however,
and so
conversation
like
is for some people.
I know. And then on that note, I'm going to get, it is a little awkward to say, but like performance wise, not performance wise, because that's like a guy term, but it's like, what if you don't orgasm anymore? Does that mean you can still have a good sexual experience? Like the end result is always the topic, right? Like, oh gosh, I can't orgasm anymore. So what does that mean for me? Can I still have sex? Like, I know those sound silly, but I know that those things have come up in a lot of conversations at our young survivor retreats. You know?
It's not silly at all. And it's, sex is not Hollywood, like jumping in the bed and in 5 seconds, like it's the best thing ever. And like everyone has an orgasm. It's like, that's so not true. It's not real life. You don't have to have an orgasm to have a satisfying sexual experience. You don't even have to have penetrative sex to be intimate and have a sexual experience. And there's all these different ways you can do that, not just foreplay, but there's other ways to be intimate that you may not even think about. And so that's kind of where, talking to your partner, or if you're not partnered, just thinking about it in a different way, you can have these intimate experiences, even sexual experiences, without even having sex.
Yeah. So, okay. That's a really great way to put it. Cause I think the pressure is on when you're like, oh my God, my body's turned off. Do I still exist in that realm anymore? So sounds like getting playful and interested and
everybody's
in the mood
different
with yourself.
And everybody's different. Everyone responds to different things, and you're going to respond totally different to different stimuli after your treatment. So just get to know it, and, open communication. And it's like, it's not Hollywood.
Because I mean, just like really what you were saying before, we're still women, even without the hormones, right? So it's just getting to know like ourselves, and we still have a little bit of hormones, right? Like we're never completely devoid of hormones, right?
If you were devoid of hormones, you would die, because hormones do important things in your body. So there's I guess some there.
So we're still women. So it's just about really getting to know ourselves and really loving ourselves through this, because nobody else is going to love us as well as we can. And then once we start to discover that, we can share that with our partner. Like, hey, it's different now. Let's do this. Or,
And there's a book that I read recently that I think covers a lot of these issues, whether it's like getting to know your anatomy, masturbation, toys, even dating for the first time after treatment. And it's called Sex and Disability, but I hate even talking about it, because I don't want women who have a history of cancer to think of that they have a disability. But it's all about getting to know your new body, and kind of like safe ways to do that, and encouraging you to kind of explore that. And so I looked it up online and read it online. It was like a day's read, and it was fascinating. And a lot of young women ask me, like, I'm not partnered. How do I even get out there again and start dating? Like, I am the worst person to ask for that, because I couldn't even manage dating apps when they came out. And that was like a total nightmare. But it even talks about that. And so I've actually thought that was really helpful. It gave me a lot of advice to tell patients. So it's not a disability, but there's some really interesting ways to kind of think about it that I found in that book. So if someone's interested, they could look it up.
Perfect.
I tell patients not to be afraid of toys, and I like sexual devices, and I have like 77-year-old patients, and I have to kind of like go through this with them. They're like, no way. But then other ones are like, yes, finally someone gave me permission. But if I'm a doctor and I'm telling you it's like a prescription, don't be afraid of it. Like there's all different kinds of stuff. Like in the olden, you know, we think of these things as being like these really big, intimidating products, but there's like totally a wide range of products out there, vibrators, stimulators, different things. And I recommend going to one of these shops that sells them, because everyone that works there is always super cool. They're very well informed. They're very open, and you can tell them what your deal is and what you're looking for. And they have the best advice. And anytime you're looking for toys, just stick to silicone ones, like non-porous materials. And then you're also going to want to wash them with like special gentle soap, and just like make sure, you know, like hygiene, keep that, because you wouldn't want to irritate your vulva with those. But I give everyone permission to go look that up. So the other thing is podcasts can be helpful in kind of like getting those highways in your brain lit up again. And so Dipsy and Quinn have these like sexual stories. It's like designed by women for women. Like there's something for everyone. I just encourage people to go just take a look at what they have, like accents, all kinds of stuff. It's really interesting, and they're like by women. Yeah, and then I also encourage patients like to, if seeing something like a film is what they're into, I just tell them to stay off YouPorn and Pornhub, because those are really bad companies and you don't want to watch those. But if you Google ethical porn, there's whole production companies of like sensual videos and sensual stories that are geared towards women. And like there's really cool articles on it that give you like a list of all the sites. And you have to pay a little bit for porn. And if you're gonna watch porn, you need to pay a little bit, because you need to make sure that all the actors and everyone's getting paid for their job.
And is of age and not trafficked. I mean, like you said, there's a lot of weird
It can be a really
to,
dark, it can be a really dark part of the world, but there's also this really bright and shiny part of it that I encourage everyone to try to find, because it's actually super interesting.
Perfect.
Typically, I know I want to be cognizant of everyone's time. There's two pharmaceutical options for low libido. One is flibanserin or Addy. It's a once daily pill. It works in the brain. It's not hormonal. There's studies ongoing for women with a history of breast cancer. It may have an interaction with tamoxifen, so just talk to your oncologist. Sometimes women feel dizziness. They used to say you can't drink at all if you're taking this medication, but the FDA actually lifted that. You can have a glass of wine or two when you're taking this medication. You just don't want to drink in the 2 hours after taking it every night. Yeah. Effectiveness varies. Like, the studies show that women have an increase of 1 additional sexual act per month. And so if you're someone who goes from 0 to 1, that's a huge deal. But if you're going from like 9 to 10, that's maybe not a big deal. And you probably wouldn't be taking that medication anyways. But the brand new thing on the market is this bremelanotide. It's an injection. You inject your abdomen before sexual activity. And I haven't seen anyone or talked to anyone who's used this, but it's something out there for cancer patients who have like a history of getting all these injections. I can't see that that would be the most attractive thing, but there's something on the market and the people are working on it. And so it's to be determined, but they're out there.
Okay. Wow. Interesting.
Yeah. They have interesting websites, so check them out. The newest thing that I recently discovered is Rostella by Bonafide. It's a non-hormonal plant-based supplement. Usually I'm kind of wary of supplements. I tell patients to be really careful, not spend a lot of money, just because there's not a ton of evidence on taking a bunch of different supplements, but that's a totally different webinar. But this is, the active ingredient is this pine bark extract, which has actually been used in Europe for a long time. And they have the data on this showing that it's safe and that it's effective. And it kind of works like nitric oxide, which is dilating the blood vessels. And it works that way to kind of increase blood flow. So it's been shown to be effective. I haven't had patients that I know of. I've had some people tell me about it through the music Instagram, but I haven't had any of my personal patients take this yet, but something to look into.
Interesting.
And and so it's good to know there are things coming out. It's a process, but just check back frequently. So, and the more we talk about it, the more companies are going to really focus their resources towards it.
And I like what you said. The more people that bring this topic up, obviously they're going to list out to you, okay, we're about to inject chemo. The side effects are yada, 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 yada. But I think as female patients, we can dictate those conversations the more we bring it up with our doctors, whether they have the answers or not. And yeah, if they're a good doctor, hopefully they can get you answers or steer you to somebody like you.
Yeah. And exactly. And we want to help. Like we're, it's in our nature. So if we don't know the answer, we try to figure it out for you.
Yeah.
So other side effects that can really contribute to zapping your sexual health are managing other painful issues like bone pain. Physical therapy and acupuncture have been shown to be helpful. The pain associated with AIs is real. Sometimes switching between them can be helpful. So if you're taking exemestane, taking anastrozole, duloxetine is an antidepressant you can take in low doses, sometimes helps. Also exercise every day. It seems counterintuitive, but that can really help with the pain with AIs. Hot flashes, you can have non-hormonal treatments for hot flashes. Venlafaxine is a low dose SNRI, which is different from those SSRIs I told you about before. And it can really, because hot flashes are a process that happens in your brain where your thermoregulatory system goes haywire. And venlafaxine is shown to be helpful. Gabapentin might help, but I try to stay away from it because it can really sedate you.
Okay.
Hair loss, 5% minoxidil, which is Rogaine. It's safe to use in cancer patients. Just talk to your oncologist, but there's no recommendation saying you can't use it on your scalp. Rosemary oil, I've read from a dermatologist, is also helpful. Bimatoprost is Latisse. It helps your eyelashes grow, but you can also use it on your eyebrows after chemotherapy, and then waterproof brow color. There's a rash associated with HER2 treatment, so topical steroids, and just going to see a dermatologist if you're having any skin issues so that you can get that aspect under control. So you wouldn't want to change any meds without talking to your oncologist. These are some of the resources I use. This is the music Instagram at the top. Where I try to post helpful information, evidence-based information. There's a website to find a sexual therapist in your area. I like the Sex with Emily podcast. It's a really great sex-positive podcast where she talks about absolutely everything. Urogynecology is a subspecialty that addresses urinary issues and sexual health. So you can find a urogynecologist in your area. You can ask for a referral from your gynecologist. Psychology and psychiatry, obviously the mind is involved with everything, and then maybe finding your local pelvic floor physical therapist. So those are all resources that I point patients to. And lastly, just like Hollywood's not real, like it doesn't have to be perfect. A lot of women are like waiting for everything to come together, and it's going to be trial and error. You have to see what works for you, and takes dedication, but you can do it. So.
Thank you, Dr. Rojas. Thank you so much for all of this information. It was a lot. And the good thing is you're going to do a live Q&A with us here shortly. People who are watching, if you have any specific questions, please put them in the chat box for Dr. Rojas, and we'll do our best to get to as many as we can, and as well as emailing a resource sheet out to anybody that Dr. Rojas has prepared for us. And you don't have to get it perfect. You just have to get it going. And I love that. And it's hard to have the sexual conversations, I think, for a lot of women, just because of all the emotions wrapped up. But I love that you keep it playful and interesting and obviously important. So let's get after it, people.
I give everyone permission. And if you need reinforcement, you can go to the Music Sex After Cancer Instagram, and my Twitter is my regular doctor account where I talk about a lot of breast cancer related issues. So
follow up with Dr. Rojas on her Music Sex After Cancer Instagram. There's a lot of really great information and resources there. So thank you so much for your time today, Dr. Rojas. We really appreciate you.
Thank you for including me. Thank you so much.
Have a good day.
Take care. Bye.
All right. Wow. What a robust and incredible topic. I feel like there was so much juiciness in there. I mean, the chat was going off. It looks like a lot of you guys were engaged in there. We have so many great questions. Dr. Rojas, thank you so much for joining us live. Thank you for taking the time to do the interview. And then also thank you for joining us live here to answer some questions, some really important questions. It sounds like a topic that it's kind of scary to talk about. And so creating this safe space where we can come together and have these hard conversations is so important. So I'm just really grateful that you're here. I'm going to bring Suzanne Garner, if you want to come on first. And before we jump into her questions while she's coming on, I just want to let everyone know that we are going to be doing a raffle for 2 Sunbum packs and 2 Pura Vida packs at random. Frankie will DM you, so nothing to do, but I just want to let you know. So look into your DMs. Suzanne, are you there? It takes a second for people to come on live. No? Okay. So, did you want to say something?
I was just gonna say, watching yourself is very interesting, and I feel like I was watching myself on fast forward, and so if you guys didn't catch anything, but there were some things that even I didn't catch myself say. So head to the music Instagram, because everything I talked about, I've posted on. So yeah, I'm gonna make a conscious effort to speak slower.
I love that. Well, I just think you want to, I do a lot of podcasts, and you want to deliver all of the content and all of the value, and which is great because you want to overserve, but sometimes it is hard to just jam it all in. I feel like we could spend a whole retreat, a whole 4 days on this topic specifically. Meg's out there going like this. So I will just answer or ask, Suzanne's question for her. What she says is, what exactly is happening in your body that causes a hot flash?
Yeah, great question. So it's actually nothing to do with your sweat glands or your body, but it's something that's happening in your brain. So the hypothalamus, which is in the center of your brain, very small, is in charge of temperature regulation. So it helps warm you up, because your body has a way of warming up when it's cold outside and cooling off when it's hot outside. And it's with estrogen deprivation, where the estrogen goes really low, that disrupts the way that the hypothalamus works. And it's hard to imagine, but it's all happening from this small little area in your brain that's sending a nerve message to the rest of your body, telling it that it's really cold. And it's just like a system gone haywire. That's why actually the medications like venlafaxine are really helpful for hot flashes. It's like a low dose antidepressant. It's like lower dose than we would normally use. And that is really the most effective thing for hot flashes. So if they're keeping you up at night and messing up your next day, venlafaxine, I know everyone's really averse to antidepressants, but this is a baby dose, and it really, and patients really do benefit from it. Hot flashes do tend to get better, but the vaginal dryness and those symptoms don't always get better, and sometimes they can get worse. So
what? No. Okay. So next question, Vero, are you there? Can you pop on? I know you're on your 11-year-old's computer, but hopefully it's
sorry
working.
about that.
I am. Here I am.
Okay. Awesome.
I don't know what my question was. So I'm trying
Want me to read it for you?
I think you kind of answer it, but go ahead. You can read it.
It just said, would love to know if there's a supplement or exercise I could do to help in the department of painful sex.
Yeah, so she answered as far as like maybe exercise and trying to find physical therapists that specialize in that. And then she talked about, didn't you talk about?
I feel like we're testing you.
Sorry.
Yeah.
I kind of know what I asked.
It's not an exam.
Okay.
Yeah. So about the pelvic floor, so general exercise can really help, your brain chemistry. You feel better about your body. I'm sending patients to Zumba all the time. That might sound corny to someone, but I think that dance is really great. And then with regards to the physical pelvic floor physical therapist, so, a lot of, in the olden days, when we didn't know that much, we would say, oh, you should just do Kegels. And Kegels are where you tighten those muscles and relax. Yeah. For women who are having these symptoms, Kegels are not the answer, because sometimes doing those Kegels can make the pain even worse. And what you want is to relax those muscles. You may not even realize it, but one of those muscles in your pelvis, that's like the bowl that sits, kind of holds in your all of your important organs, they may be spasming and you wouldn't know because it's involuntary. And so sometimes what you need is to relax those muscles, and it can take some biofeedback with a physical therapist or relaxation exercises and direct feedback with a specialist to help with that.
Of that. Great question. Thank you, Vero.
Thanks.
Okay, next question comes from, I'm hoping I'm going to say this right, Tierney. Are you there? And this question looked like it was kind of in response to another question. So
yeah, sorry.
Okay. No,
Can you hear me?
Hi. Yes.
Hi.
Did I say your name okay?
Yeah, no,
Okay.
that's fine. It's
Perfect.
it's pretty phonetic. So,
Okay.
No, so I've read your little music blog thing, because I've heard of you before, and I've tried the lubes and the stuff, and I've got that in the painful sex. I've got it all under control. My libido is down, but I'm having a hard time with like orgasming. Like it just is not working.
Yeah. Thank you for saying that because it's actually a pretty common problem. And one thing that I have found that has some data on actually helping with arousal and increasing blood flow and kind of helping with that specific problem is low dose vaginal testosterone. It's not on the market. And I kind of explained it, but I was talking very fast. But the testosterone in the vagina is converted to estrogen right there, and it stays there. So the estrogen doesn't go into your bloodstream. Even if you're on a medication like anastrozole or letrozole, it doesn't change the levels of estrogen. And so there's one commercially available form of this, and it's called Intrarosa, and it's a prosterone suppository. But the problem is, if you don't have commercial insurance, you're not eligible for their coupon program. It's FDA approved for painful sex, but it's the same kind, it will have the same kind of effect and may be able to help. I think sometimes the inability to have an orgasm can be can be helped with low testosterone, very, very low dose just in the vagina. The other thing is, some antidepressants can make it completely impossible for you to have an orgasm. Medications like Zoloft, Paxil, and those. So sometimes in patients, and that is, yes. Yeah, and so this is the deal. There is a solution. Talk to your psychiatrist, because bupropion or Wellbutrin does not have sexual side effects. And so I don't want anyone to stop taking their antidepressant medication, but sometimes switching, and this should be only done with your psychiatrist and being monitored, but Wellbutrin or bupropion does not have sexual side effects.
Okay. It's not like the most important thing. With my partner, we've been working on other things, and I think it bothers him more than it bothers me. I'm fine with the intimacy and the just being with him, but it bothers him. That's not.
I understand.
So.
Yeah, and we shouldn't be faking these things anymore. I should just go out and say it. So let's find solutions, and yeah.
Yeah, it just speaks to the larger effect that this has, and why it's so important to have these more granular and finite conversations. So thanks, Tierney. Okay, so next question comes from Camille.
Hi. Hello.
Hi.
Hi, Dr. Rojas. Hello. I love your Instagram page and everything that you post and share. Thank you. My question for you is, I went and tried 3 sessions of the Mona Lisa laser because I wasn't having much luck with other options. So I was really hesitant because it's so expensive. But I didn't notice any difference at all. After 3, gynecologist says to keep doing it and it will improve. Do you think that there's any reason to keep doing it past 3 sessions if there hasn't been any improvement?
Yeah, I'm so glad you asked that question, because so my deal with the lasers, like the Mona Lisa laser, is that they were originally designed for the face and for other parts of the body. And now they're being marketed as part of vaginal rejuvenation. But the problem is that a woman not on breast cancer with a history of breast cancer treatment, like a normal postmenopausal vagina, may have a different response to that laser than someone who has really, really low estrogen after chemo. Are you taking an aromatase inhibitor like letrozole?
Yeah, letrozole.
Yeah. So that's the specific medication that those three make your estrogen so incredibly low. It interferes with wound healing. So the whole basis of that laser is that it causes these tiny little microscopic injuries in the vagina, like tiny little burns. And if that tissue can't recover, then you may not have the effects that another woman who's not on that medication would have. The studies looking at women who are taking anastrozole or letrozole, there's not that many patients in them. They haven't followed them for that long. And so right now, I try to steer patients away from the laser, especially if they're on that medication. Sometimes in women on tamoxifen, who you can give them vaginal estrogen at the same time, I think that may be a better option. But right now, without the long-term safety data, I try to steer away from it. So for you, I wouldn't keep going. I would say if you've done it 3 times, you should have seen an effect by now. So you may be someone who maybe doesn't respond that way. And that's the thing about those devices, is that everyone can have a different reaction. And all of the studies were sponsored by the machine, the people that make the machine. And so so for things like that, I just caution everyone, but I'm not saying it wasn't. There are some women who take this medication who get this treatment. I'm not saying it was the wrong thing to do. And, you know, I wouldn't spend any more money if you haven't had any symptom improvement in 3 sessions. But, you know, doing all the other things and then thinking about, for you, a vaginal hormone, low dose, either like an estrogen or the low dose testosterone, that may be really the best bet for you, especially if you didn't get any improvement with the Mona Lisa.
Okay, thank you so much. And thanks for saving me a lot of money.
Right. Okay.
Yeah,
go ahead.
You guys are a vulnerable population, and you know, you've tried so many things. You've been told, no, you can't take this. No, you can't take this. No, you can't do this. And so like companies are going to target you. You know, this is Breast Cancer Awareness Month. There's pink washing. There's all these negative aspects of unfortunately your survivorship. It's really not fair, but I try to just be really careful and look at the data on especially devices, because, you know, and some offices, you know, I just wait for long-term safety data. Just take everything with a grain of salt. Sorry to interrupt you.
No. There's no interruption. It's your floor right now. Okay, so we have one more question. We do have a few more questions, but we only have time for one more question. So these other ones we're going to submit to you, and hopefully you can get back to them at a separate time. But Jamie, I think it's Jamie. You there? We'll see if she is there. Maybe it's Jamie. I don't know if there is a Jami. Oh, sorry. Okay, no problem. I will ask your question for you. She said it's too loud for me to ask my question. Okay, so her question says, I'm 40 years old and have 3 more years left of anastrozole. Sorry.
Anastrozole, yeah.
Anastrozole, sorry. I'm wondering if you have seen women's bodies, quote unquote, go back to normal after 5 years of an AI, if they're premenopausal.
Yeah, so great question. The deal is, and you'll have to talk to your oncologist, they may end up recommending 10 years of therapy for you, especially if you were diagnosed in your 30s. The guidelines for women diagnosed in their 30s, usually oncologists at the end of 5 years will recommend another 5 years, or they'll run a special test called the breast cancer index to see if it's worth it to add another 5 years. So in your case, because you were diagnosed before the age of 40, it's a real possibility that your oncologist is going to recommend you're on longer than 5 years. And those guidelines have recently changed. So the answer is a premenopausal woman who has this temporary lowering of estrogen, who goes back to being premenopausal. You know, it all depends on if you got chemotherapy, then that may inhibit your ovaries from kind of bouncing back, or it may make that process a little bit more gradual. And some women, but usually it's women older than like 45 who get chemotherapy, they usually don't have their periods come back. And so those women are more at risk for the permanent issues. But women who become premenopausal again and start to have the changes, like more blood flow, and the vagina kind of goes back to the way it was premenopausal, like that can totally happen. But it also may take a little bit of dedication and a little bit of extra work, you know, like you may still need to use lubricants, or you may still need to every once in a while use moisturization. And so I would just be patient with yourself. But everyone's body is going to respond a little bit differently. Mm-hmm.
Did you want to say something else?
I was just going to say, yeah, for patients who, like I said in the talk, who have been on this therapy for a long time, the vagina is shorter, it's narrower, it's less stretchy. And so in those patients, you know, just doing a moisturizer isn't as helpful. You know, really, if you're not sexually active, using a dilator along with the moisturizer can help stretch those tissues out to make sex less painful, if the goal is penetrative sex.
Such a good conversation. Dr. Rojas, thank you so much for being here. Thank you for being such a wealth of information and an incredible resource and advocate and light in this space. I definitely want to encourage everyone to go follow her on Instagram and follow the work that she's doing. For everybody else, we are going to jump into a 5-minute nature break. And then we will be back with one more doctor, and then we'll be wrapping for the rest of the day. So thank you so much, and just take this time for yourself.
Bye, guys.